Good evening, everyone. Can you hear me? All right. So I'm assuming everyone can hear me. Welcome on board. It's Monday, November 9th, and we're getting together for our rapid fire session on interstitial lung disease under the Emirates Thoracic Society. Thank you all for taking out the time on a Monday evening to be with us. We hope to make this interesting and interactive, and I hope that all of you take some important lessons from this, which you can apply in your daily practice. The way the format is, the session will start with Dr. Ashraf Alzaabi, who will give us a talk, and after which the case-based presentation session will initiate, and Dr. Sharina Aldhaheri will take over that, and she will moderate that session also. To all the participants, I would advise that if you have any questions, to type them into the little icon which says Q&A at the bottom of your screen. Those questions will be received by our moderator, and she will carry those out for you. And of course, all of you will be able to participate in the answer session as well. As far as when the questions are going to happen, we're just going to see how we do for time. The plan is to do them after every session. However, if we're running short, we'll do one big question answer session at the end of the meeting. So let's start. I won't take up more time, and we'll start with Dr. Ashraf Alzaabi to move forward with his talk. Thank you very much for your support, Ashraf. Go ahead.
Assalamu alaikum. Thank you very much. First of all, I'd like to thank our doctors who are joining us for this meeting tonight, and I'd like to thank Dr. Saniya Khan, the president of the Emirates Thoracic Society Interstitial Lung Disease Special Interest Group, and her colleagues, Dr. Fabrizio and Dr. Sharina, for inviting me to this interesting session. I'd like to start by an overall review that I was asked to present today by our sponsor. If I can have my talk please presented, or I can share the screen.
Yes, you can share your screen, doctor.
Thank you. Does my screen project correctly?
Yes, please click on the full screen. There you go.
Great, thank you. So in the next half an hour or so, I'd like to, first of all, disclose my conflict of interest that I've been contacted by Boehringer Ingelheim to conduct this session. And I have no financial interest in Boehringer Ingelheim. I'd like to speak about interstitial lung disease and how we diagnose them as a general pulmonologist. And then after that, we're going to have an in-depth with our expert panel of how they manage those patients when they come to their clinic of interstitial lung disease. I'd like to speak about idiopathic pulmonary fibrosis as a main topic. And after that, I'd like to speak about a new entity that has been discussed lately in the literature, and that is the progressive fibrosing interstitial lung disease. This is a normal, healthy lung. And if I may ask the organizer, I'm having difficulty progressing. I guess I have to go right and left. Yes, thank you. I think I got it. This is an unhealthy lung. It seems like people for reasons that we don't understand. Idiopathic pulmonary fibrosis is basically a result of an injury to the lung, and the lung tries to heal itself, and there is a scarring. The healing is not a healthy healing, and this results in fibrosis. And when a patient comes to me, first of all, before I refer them to Saniya and Sharina and Fabrizio, they come to me as a general pulmonologist. They come to me with an abnormal chest X-ray like this one. And this chest X-ray shows a fibrotic lung. And the fibrotic lung can have different shapes and different presentation radiographically. Why? We don't know. It seems like if you go with me over the table on your left-hand side, you see that there is a diffuse parenchymal lung disease of known causes. Sometimes we know the causes, and most of the times we don't know the causes. Pulmonary fibrosis can be caused by rheumatological diseases, and we'll speak about that. It can be caused by environmental exposure. Drugs, medication can cause pulmonary fibrosis, such as chemotherapy, for example, amiodarone in cardiology departments. And there are diffuse parenchymal lung diseases of unknown causes, such as granulomatous diseases, such as in sarcoidosis. Idiopathic interstitial pneumonia, worst one of them that we don't like to see is the bottom one here in the chronic fibrosing idiopathic interstitial pneumonia, the idiopathic pulmonary fibrosis, because it has very poor outcome. And there are other causes such as fibrotic lung related to smoking or other rare entities. What happens next when the patient comes into my door? The patient is hoping that his disease severity will get better, going up towards the green. I am worried that the patient disease severity, from my experience, especially if it turns out to be IPF, the patient's severity will be really worse and over a short period of time. Unfortunately, we cannot predict if the patient is going to go green, red, or he's going to go in the middle, stable for some time with exacerbations and plummeting of their clinical course. That's why we try to really sort out which type of pulmonary fibrosis my patient has. And we do clinical discussion. We meet with radiologists, and this is what we're trying to do today, multidisciplinary discussion of cases. We discuss pathology biopsies, if we do biopsies with our pathologist, in a setting called multidisciplinary discussion. And when we see the patient, we'd like to know, is this an idiopathic interstitial pneumonia or it's not an idiopathic, because this matters. We discuss the radiology because the radiologists say this is very diagnostic for this disease, a diagnostic pattern, and sometimes it's not diagnostic. The same applies to the pathologist, and this help between the clinical history, physical examination, together with the radiologist and with the pathologist to make our confidence in the diagnosis better. The diagnosis is really important, and our confidence in the diagnosis better because we know, if you look at the graph, the top graph, for example, here shows a group of patients who have fibrosis because of chronic hypersensitivity pneumonitis. Idiopathic pulmonary fibrosis. The mortality is highest if the pulmonary fibrosis is caused by idiopathic pulmonary fibrosis. If you see my cursor, if the interstitial lung disease is unclassifiable, this is good news for our patient. If it is due to another entity called NSIP, that's even better outcome for our patient. And the best, for example, among these four is somebody who has hypersensitivity pneumonitis. If somebody has idiopathic pulmonary fibrosis because of if somebody has pulmonary fibrosis because of connective tissue disease disorder, they have much better prognosis than somebody who has it due to idiopathic pulmonary fibrosis. If somebody has, even in the connective tissue disease group, individual diagnoses do matter with regard to prognosis. Somebody who has scleroderma has worse prognosis than somebody who has rheumatoid arthritis. Scleroderma has better prognosis than rheumatoid arthritis than undifferentiated connective tissue disease, which really has similar prognosis to idiopathic pulmonary fibrosis. So even if a patient is referred to me by a rheumatologist, the individual diagnosis from the rheumatologist help me predict the prognosis for my patient. So history, clinical exam, diagnosis matters. Pathology pattern from the pathology report, if we do a lung biopsy, matters. Why? If the pathologist tells me this is a UIP, usual interstitial pneumonia, that's like a very bad prognosis, as opposed to non-specific interstitial pneumonia. It has much better prognosis. Even in the non-specific interstitial pneumonia, we know two entities. There is the cellular non-specific interstitial pneumonia, has much better prognosis than the fibrotic non-specific interstitial pneumonia. And of course, the worst among all is the UIP. Fibrosis is associated with mortality in hypersensitivity pneumonitis. Hypersensitivity pneumonitis, which is an inflammatory disorder, also has two types, the fibrotic and the non-fibrotic. The fibrotic is always worse, bad news for the patient than the non-fibrotic. Then we go to our radiologist and we chit-chat with them. So this is the CT scan. What do you think is going on? The radiologists tell us, from the radiology perspective, I think this is UIP, bad prognosis. Radiographically, this looks like non-specific interstitial pneumonia. That's much better, even radiographically. So when we read the radiology report, it's important that we focus on what they think. Suppose they say this is UIP, consistent usual interstitial pneumonia, which is the radiological pattern we see with idiopathic pulmonary fibrosis. There are landmarks in the radiology report that make us think the patient is going to do well or worse. If the radiologists say there is no honeycomb, that's really the best news we can tell our patient. If there is honeycombing, this is an advanced stage of fibrotic lung that really carries worse prognosis, even radiographically. The extent of the radiologist, sometimes the radiologists, they use score, or sometimes they estimate, they say, we think that there is more than 50% of the lung fibrotic. Does that signify importance to the patient? Indeed, it does. Higher extent of fibrosis on the CT scan means worse outcome and higher mortality for our patient. What else matters? When we see patient, it's also important we ask them in the office, so are you short of breath? How bad is your shortness of breath? And this graph nicely shows you that the survival is worse with people who have worse dyspnea in the history taking even. Then we send them for lung function and we do vital capacity check for them. And the lower the forced vital capacity when we do spirometry for those patients, the worse prognosis they may have. We do 6-minute walk test, and this is a test we do by asking the patient to walk for 6 minutes with pulse oximeter in their finger, and we measure the distance over 6 minutes. And the patient, sometimes if they have fibrosis, they desaturate and their oxygen drops. The lower the desaturation, the more desaturation means higher mortality, as shown here with the graph. Even the severity of the desaturation, those who desaturate 4% do much better than those who desaturate 10% when we walk them and we exercise them. So if the patient tells you that at home, if I walk from my bedroom to go upstairs, my desaturation drops, that's bad news. If they drop by 2%, that's much better than worse news when they drop by 10%. So far, we know about idiopathic fibrosis that it is a progressive disease that has a usual interstitial pneumonia UIP pattern on the high resolution CT, and on the pathology, if we need to do a CT scan, usually involve people who are more than 50 years of age. It affects 10 per 100,000 patients, males, and a little less in females, 7.4, and 60% are current or former smokers. The rate of decline in pulmonary function, namely forced vital capacity, appears to predict mortality. So far, that's why a lot of the studies that tried medicine to treat pulmonary fibrosis focused on the forced vital capacity as the primary outcome. Antifibrotic options were not available to us in the respiratory field until about 10 or 15 years ago. And we have so far 2 antifibrotic agents. It seems that most patients with idiopathic fibrosis, which is the main focus of my talk in this part of the talk so far, most of them, they come in with a classic history of worsening shortness of breath, not over days, but over weeks and usually months. How many months? 9 to 12 months in up to half of the patient population. So it's a chronic, worsening, progressive shortness of breath. Key diagnostic criteria is to, when we see the patient, is first of all, when we see the patient is to exclude other causes of diffuse parenchymal lung disease. As I said, why? Because the prognosis is way worse if the patient has idiopathic pulmonary fibrosis. So we really screen them for interstitial lung diseases due to, for example, rheumatological disorder, drugs, other causes, hypersensitivity, pneumonitis, and we combine our history with radiology and the biopsy. Prognostic value of the high resolution CT scan has been shown in many studies, and I've gone over that. Then we meet together, radiology, pulmonology, pathologist, and we discuss the following, and I suspect our panel will have this ready for us. We discuss the following. We discuss the CT scan, history, we look for the age, the gender, smoking habit, connective tissue disease feature, possible irritants or exposure to hypersensitivity pneumonitis precipitants, Levats, sometimes we do that. We usually don't need to do that, except if the picture is atypical, and we look at the patient disease behavior. Why do we do multidisciplinary team discussion? Because change in the interstitial lung disease diagnosis was noticed in more than half patients suspected to have interstitial lung diagnosis. Change the diagnosis if you discuss it with the interdisciplinary team. Unclassifiable interstitial lung disease, the diagnosis of unclassifiable was reduced from 40% to 12% if you do it as a team. 37% of patients changed their diagnosis. 8% had their diagnosis changed to IPF. So it's really important. A lot of people ask, do we need to do bronchoscopy for everybody suspected to have interstitial lung disease? Only if the CT scan is not typical of the usual interstitial pneumonia pattern. And what do we benefit from the bronchoalveolar lavage? We look for the cell type. Predominance of cell type. If we see a lot of lymphocyte, we think something like inflammatory disorders such as hypersensitivity pneumonitis. If we see a lot of neutrophils, and neutrophils usually are the cell type that we see with idiopathic pulmonary fibrosis. We usually lose lung function as we grow. After the age of 20, we lose about 30 ml per year, 30 to 50 ml. People who develop idiopathic pulmonary fibrosis loses a lot higher, 150 to 200 ml per year. And it is known that idiopathic pulmonary fibrosis is irreversible. So even with any medication we give our patients, we cannot stop the decline in the forced vital capacity. We can only slow this decline, but we cannot heal the lung correctly like it was. And unfortunately, some idiopathic pulmonary fibrosis patients drop and go really bad very fast, and some of them continue to be relatively stable and decline slowly. Unfortunately, a lot of those patients, they decline really bad if they develop an incident called idiopathic pulmonary fibrosis exacerbation, acute exacerbation. And these are known incidents where patients usually get admitted to the hospital, and they're associated with high morbidity and sometimes mortality, up to 50% of those patients. And I'll start with the treatment for idiopathic pulmonary fibrosis. So far in the literature, we have two agents. One of them is pirfenidone, and it has been shown nicely to decrease the decline, as you see on this graph, in the forced vital capacity. And pirfenidone, although this was not the primary outcome, has been looked at as favorable outcome when it comes to survival because of the decline slowness in the FVC. And the other drug that we use in our practice is the nintedanib. Nintedanib has been studied on a large scale and for a long period, and we have two famous studies that studied this medication, INPULSES 1 and INPULSES 2. And what this study showed that people who took nintedanib and were followed over a year, they noticed that the decline in FVC was reduced in the treatment arm from 240 ml to 114. And the same result was replicated by another study called Impulses 2. The FVC decline as a primary outcome was reduced from 200 ml to 113. And in pooled data, this was confirmed. And this graph will remind you of the pirfenidone study. Similar to it, there was a strong signal of efficacy for this drug. The beauty about nintedanib is this study that's called Impulses On trial. What they did after they finished the Impulses 1 and 2, after 52 weeks, they took the placebo arm, the light blue, that were not taking nintedanib, and they put the placebo arm on the nintedanib, and they followed them, and even they continued the nintedanib arm. And what did they show? They showed, like the other study, that data from Impulses On suggests that the effect of nintedanib on slowing the progression persisted for up to 4 years. So I really like the fact that this study has been going on for 4 years, and it showed that the decline in FVC continued to be less in the treatment arm, even though patients who were put on this treatment were already very advanced from the placebo arm. And it seems like it has a good safety and tolerability profile, and no safety signals were identified. Now, when it comes to mortality, I have to say that we have to interpret this study. There was a recent study from 2019 by Lancaster at the British Medical Journal, and it suggested that there was a signal of survival benefit. However, this survival benefit, I have to say, we have to be careful because it was not the primary outcome for the study. But this was both noticed in two studies when it comes to 2 follow-up periods. So next, I'd like to go over with you on the new drugs. So both drugs, so far I've said that nintedanib and pirfenidone, both drugs have a favorable effect on in-treatment mortality, despite the fact this was not a primary outcome. So what's new in the horizon? What's new in the horizon? As I mentioned earlier, that injury to the lung results in activation of coagulation cascade, antioxidant pathway, fibrocyte circulating cells, macrophage circulation. This leads to imbalance between the healing and the scarring. You get profibrotic mediators and you get antifibrotic mediators. This imbalance leads to endothelium epithelium fibroblast activation, and the result is excessive extracellular matrix deposition. One study that I'd like to share with you is a new study. This is a phase 2 trial on a drug called ziritaxestat. It's an LPA. And I'll have to write it down because I wouldn't remember the name. Apparently, there is a pathway called the LPA pathway, lysophosphatidic acid pathway. And this drug is called a GLPG 1690 because it's still a phase 2 trial. It's an autotoxin inhibitor. Autotoxin inhibitor is a simple term to remember this drug, and what it shows that they gave this drug to people who were already on antifibrotic agent, because ethically, nobody will give you an ethical approval to not give one of the 2 antifibrotic agents nowadays if somebody has idiopathic pulmonary fibrosis. And this medication was tried only in the idiopathic pulmonary fibrosis. And what it shows that the FVC in the treatment arm was better. It did what they expected it to do. The FVC is stabilized, and change in the plasma level of the LPA, which is the bad
Sorry
guy.
to interrupt.
Yes.
We're in our last minute.
Okay, sorry about that. So this is a new drug basically, and it shows that, I apologize, I thought I had 30 minutes. So this is a drug that showed that there was a hope for a new medication that you can add as an add-on. Then the last minute I'd like to spend is basically that there is another entity called Beyond Idiopathic Pulmonary Fibrosis, people who have pulmonary fibrosis, not IPF, but other causes such as rheumatological diseases, such as scleroderma, and it's a progressive, or hypersensitivity pneumonitis, and it's a progressive. And a new study that came out 2019 for a group of patients, more than 330 patients with the same placebo arm, and what it showed, if the patient has a progression in their fibrosis of more than 10%, of their FVS, more than 10% decline in their lung function, in the FVC, or worsening symptoms with FVC decline, or worsening extent of the fibrosis as per the radiology, they put them on the nintedanib, which was initially used only for IPF. But those patients have no IPF. They have pulmonary fibrosis due to other causes. And they noticed that, similar to the IPF study, the annual decline was assessed over 52 weeks, and they noticed that most patients who got the treatment did much better. Their FVC from the placebo dropping their FVC 187 ml per year, it went down to 80 ml per year in the nintedanib group in the overall population. And for those who had UIP-like pattern, similar finding, even better, was noticed. So another hope for people who have pulmonary fibrosis, not because of IPF, we can still consider treating them with nintedanib, and adverse effect leading to permanent discontinuation of the study was, as expected, noticed as in a higher group in the nintedanib group, 19 patients as opposed to 10 patients in the placebo group. I'd like to end up my talk by saying that interstitial lung disease represent a challenge that need a multidisciplinary team approach to reach a diagnosis. Symptoms, lung physiology, imaging, pathology are important tools to predict prognosis for our patient. Early treatment is very important to slow the decline because it's an irreversible disease, and there is evidence for patients with progressive fibrosis, interstitial lung disease, to benefit from fibrotic lung. Plus, there is some studies now into phase 3 trial to try an add-on treatment to those antifibrotic agents. I'd like to thank you again for inviting me, and hope to see a nice, fruitful meeting for the next couple of hours. Thank you.
Thank you very much. And we're going to now move on to Sharina. Sharina, if you have any questions for the session. That was a great talk. It makes our job a lot easier with our talks. Thank you, Dr. Ashraf.
Thank you.
So Sharina, on to you.
Hi, Assalamu alaikum. Assalamu alaikum. Good evening, everybody. Thank you for joining us today in ILD webinar. So what we're going to do right now is we're going to discuss 3 cases. The first case is Dr. Fabrizio will present the first case. So we will try to make it like 20 minutes, 30 minutes in total, like 15 minutes discussion of the case, and then 5 minutes we'll discuss, 5 to 10 minutes we'll discuss the radiology and as well as the discussion. So we'll start with the case 1. Professional IBF. So Dr. Fabrizio is expert in ILD. He's working in Blant Clinic in Dubai. So Dr. Fabrizio, go ahead.
Thank you for the introduction. I'm going to share my screen. So you might see that the professional idiopathic pulmonary fibrosis is with the idiopathic in the comment, inverted comment. What we are going to, I'm going to discuss tonight is about what it is, professional exposure, and the presence of UIP pattern slash IPF. We'll discuss about a clinical case, about open queries I have about the clinical case, and if I have possible solutions. So, first of all, the diagnosis of IPF requires a detailed history, and basically detailed histories must include exposure and work exposure, especially, as was quite nicely highlighted by Professor Alzaabi. And the exclusion must include also exposure to known dusts. We know that there are professional exposures which causes UIP pattern. For example, exposure to plutonium alpha radiation can cause lung fibrosis, and that's not a rare condition in those workers. We know that polonium is present in cigarette smoke and also release alpha radiation. We know that wood dust exposure in workers can cause a UIP pattern, quite often mistaken as IPF. Indeed, in a short series cases, it was reported as a IPF, and then after, when the cases were reviewed, were noted that patients were exposed to wood dust. So, moving through the bronchoalveolar lavage, and so if we have a UAP pattern, quite rightly has been highlighted that the BAL is not required, but I would say if we have exposure, the bronchoalveolar lavage, it can be very useful also in UAP pattern. For example, in welders, there is the evidence of macrophages with hemocysteine-laden coloration. And so BAL is not required when you are safe with the diagnosis, but I'm wondering when are we safe? So we know that the occupational exposure can cause interstitial lung disease. I just briefly mentioned that nanoparticles like carbon nanoparticles can cause UAP pattern, ceramic fibers, coal dust, but also asbestos, hard metal exposure, and aluminium can cause UAP patterns in workers in these environments. So recently in 2018, has been published a registry of IPF patients in US, and they noted that about 1% of the patients were busy with dental work. So about 8 dentists and 1 dental technician were found in this database. So this is a remarkably high percent of one profession in a rare disease like idiopathic pulmonary fibrosis. So what we know about our case is that a 58-year-old gentleman, dentist with a history of gastroesophageal reflux and irritable bowel syndrome. He first had a high-resolution CT scan of the chest in 2018 because of abnormal chest X-ray findings. He was asymptomatic at that time and remained asymptomatic for 2 years. And then symptoms presented since he started using a facial mask because of the COVID pandemic. And within 3 months, from a mild dyspnea, he went to a very, very severe dyspnea. And later was also associated with supraventricular tachycardia. It was first seen by me in July, at the end of July, and it was on treatment with oral steroid. It was too breathless for invasive investigation. So we did a pulmonary function test. You can see a restrictive pattern, typical. It was not even able to blow longer than 1 second, so we don't have a FEV1. We made also the diffusing capacity, and you can see that the total diffusing capacity is significantly reduced, 26% of the predicted value. We did also walking test, and the patients were desaturated on 1 liter, on 6 liters of oxygen after the 3rd minute. And this was not a great improvement because he also desaturated at the same level when he was in room air. So we made an overnight oximetry in room air, and his oxygenation was mean oxygenation was within the normal limits, but 35% of at night was spent below 90%, making nocturnal respiratory failure. And there was no evidence of significant oxygen desaturation. The blood gas in room air at rest was showing that there was mild hypoxia. Made also an echocardiogram, especially because of the discrepancy between the severity of the desaturation on walking test and also because he had a previous other 2 echocardiogram, one which was reported as normal and another one reporting severe hypertension. And indeed, we confirmed that there were signs of severe hypertension with an estimated pulmonary pressure of 65 ventricular pressure. We tried to screen for cognitive tissue disorders, and we didn't find. There were no symptoms suggestive of. We then reviewed the CT scan of 2018, and the CT scan was already reported in 2018 diffuse interstitial lung disease, and they were advising clinical preparation. So this is the upper part of the lung, the upper lobes. You can see diffuse reticulation, honeycombing, some traction bronchiectasis, bronchiectasis. So the findings were actually dismissed by their family medicine doctor who was following the patient as your lung has some scars. Because the patient was not very much symptomatic at that time, despite the CT scan, he didn't pay more attention to that. Then, when he became very symptomatic, he repeated the CT scan, and the CT scan showed the extensive honeycombing in all segments, prevalently in the subpleural regions associated with ground glass, possibly used as interstitial pneumonia. So this is the scan, is a video. It starts from the lower lobes. This is, it wasn't done in my clinic, it was done before seeing me. You see much more extensive honeycombing, traction bronchiectasis. So the report was referring of ground glass. In my opinion, there is no significant ground glass.
Dr. Fabrizio, do you think it will be useful to ask Dr. Mahmoud to review, to compare both CT, and then we can take it?
Okay.
What do you think, Dr. Mahmoud?
Can everybody hear me?
We do also the GAP index and the GAP index to show a predicted mortality of 16% if this is IPF. Although I made a star on that result because the FVC was just borderline 51% to increase the number. In addition, there was a significant rapid decline. So my MDT meeting is a strange MDT meeting because I have to contact singularly my colleagues, is Dr. Michela Romagnoli, Dr. Alex, the radiologist, and the rheumatologist. And occasionally I meet also experts, someone might recognize Dr. Poletti and Dr. Dalpiat. and there are also editors of books. My opinion was that we should have differentiated the IPF from hypersensitivity pneumonitis and consider also professional exposure. And the MDT meeting was going in one direction. They noticed the extensive honeycombing reticulopathies, ectasis, subpleural predominance. We took into consideration the profession. That was an extensive involvement of the upper lobes, no clinical serological evidence of chronic tissue disorders, no history of organic dust exposure. And they also recommended to go further with investigation, considering the pulmonary hypertension, to do a Ctpa to rule out chronic PE or lung thrombosis. And the definition was definitely UIP pattern with IPF and pulmonary hypertension, which is secondary to the lung disease. So the patient now is on treatment with nintedanib, is on sildenafil Viagra because revascularization is intubated with UAE. The cardiologist recommended to start propranolol because of the supraventricular tachycardia we developed lately, and is on antacids, and because of prostate is on peninsula. And when he has irritable bowel syndrome, it takes his busparin. We went on, so we made a Ctpa. So we make no comments, so we'll give space to my colleague.
So Dr. Mahmoud.
Yes,
Dr.
hello.
Mahmoud. Yeah. Can we review? Can we go back and review the CT, the first CT?
Yeah. Yeah. I don't have control of his slides. Can he goes back and?
Yes. Dr. Fabrizio, can we go to the first CT in 2018?
Yes, I'm just showing the Ctpa and then I go back.
Okay.
Okay, done. Going back.
Yeah. So we are dealing with 50-year-old gentleman who was asymptomatic, had abnormal chest X-ray. Subsequently, he had the CT chest found to be abnormal, and he was doing well until 3 months back when he started to develop shortness of breath and progress rapidly.
Okay.
He had no connective tissue disease symptom. Connective tissue disease serology was negative, and he has no exposure to organic dust. Is that right, Dr. Fabrizio?
Right.
Okay. So this is a CT in 2018. If you can take us through, Dr.
Yeah. So okay. So if I'm looking at the July 7, 2018 examination, and I'm seeing actually the image of the trachea. So basically, we are already like now in the upper lobes. We're still close to the lung apices. Clearly, you're seeing coarse reticulation that are more concentrated at the periphery, and you've got now on this image. It's tough to say what are the honeycombing, but as you go down, you're gonna start to appreciate that the severity gets even worse. So if you just stay on this image, you know, this is what we call the 4-quadrant sign of a interstitial lung disease. Basically, in each lobe, in the subpleural location, you've got areas of fibrosis. And then if you look at the center, or at least the central 2/3 of the lung, they're basically clear. They're basically completely unremarkable. So whenever we have such a feature of small honeycombing and in the periphery, like 1, 2, 3, 4, that is a UIP until proven otherwise. Now, is it an IPF or connective tissue disease UIP? Like, for example, rheumatoid is notorious for causing UIP. That's a different story. And this is basically where the clinician comes in and he rules everything else. But if somebody is showing me this image, this is a UIP picture. And it's we have the classification of the UIP is basically under typical UIP, probable UIP, and inconsistent with UIP. And the cardinal feature of the typical UIP is the honeycomb. When you don't have honeycombing, but you have all these reticulation, it becomes under probable. And if it is inconsistent, then you're like now considering HP or NSIP. So this, by imaging criteria, is a typical UIP CT pattern.
So, Dr. Mahmoud, sorry for interruption. So, how
Yes.
can you differentiate between bronchiectasis and honeycombing? I found this
Okay.
challenging to differentiate between honeycombing and bronchiectasis.
Okay. So basically, so there are actually two theories for that. If you ask the pathologist, actually, they will tell you that actually the honeycombing are actually the end bronchial lectices that becomes detached and they become sealed by themselves. Now, so this is basically why we actually, when you read a high resolution chest CT, it's a must to have the sagittal and the coronary formatted images. If you're gonna do the stack of axial images, there is no way you can differentiate if this lucencies at the periphery are actually honeycombing or actually bronchiectasis. The best way to do that is actually you put the sagittal and the coronal images, and if you can trace that to the bronchus, that means you are in the bronchiectasis. Now, the bronchiectasis actually is part of the UIP picture, and it's actually a prognostic feature as well. So the moment I see also bronchiectasis, and if I see a little bit of honeycombing, I'm actually going to call this still UIP because it does not fulfill my criteria of the NSIP. But that's why you need the sagittal and the coronal. And also, most of the PACS machines today, they actually provide you with a little bit of reformatted tools, basically call it maximum intensity projection. But there's also something called the mini MIPS, which is basically it will make the lung very black, and it will pronounce every cystic or bronchiectasis in the background. And so I also tend to use those, magical buttons in my PACS machine to accentuate the bronchiectasis, or at least to distinguish that from the honeycomb.
Mm-hmm. And does it matter if you have bronchiectasis in the upper loop or lower loop? Because this patient has bronchiectasis, honeycombing in the upper loop.
So UIP by distribution is an apical to basilar gradient, and it is a peripheral gradient. So as you go from top to bottom, the worse the disease should get worse. And as you go from the center to the periphery, the disease should get worse. That's why if you look at this image, for example, it is basically relatively normal in the middle, but it's actually more pronounced at the periphery. In a male smoker, like 60 plus, the UIP is basically our top differential before anything else. Consider a female, with a similar patterns, we start considering rheumatoid as a UIP background, or maybe there is a fibrotic NSIP that is now overlapping with a UIP picture. But something like this, that's why, so basically this is where, the MDT, the conferences with sitting down with the clinician and the pathologist is very, very much important. If I read this by myself, I'm going to be mistake. I'm definitely going to make a mistake. I sometimes, I call the clinicians. If they're busy, I check their notes. I see the serology. So I also try to do my job because, it's a completely different diseases.
So what do you call this pattern in 2018?
This is definitely the classic UIP pattern. That's the typical UIP pattern now.
Okay, so let's see the second CT, 2019, the next CT.
This was done in July 2020.
Okay.
So right now he's going the base from the abdomen. He's cutting through the liver and he's going up. So if he stops right there, you're seeing the honeycomb in the posterior costophrenic angle. That is a cardinal sign for the typical UIP. And I'm just going to read you the typical UIP pattern according to the new distribution. The distribution is basilar predominant and subpleural predominant and is heterogeneous like this case. And the features are honeycomb, reticular pattern with peripheral traction bronchiectasis or bronchiolectasis, and there is no other feature to suggest an alternative diagnosis. So as you can see, the cluster of honeycomb cysts and the bronchiectasis are concentrated in the posterior costophrenic angle regions, which is basically where is the typical UIP likes to reside. And as you go up, you're going to see similar finding, but they're going to be actually less pronounced.
Okay. So our role is to just differentiate if it's UIP pattern, probable UIP pattern, indeterminate or inconsistent with UIP, which will help narrow differential diagnosis.
Yeah.
Okay.
Yeah.
Okay, so
the radiologist mentioned ground glass. I think there is minimal ground glass in the abdomen.
I did not see any ground glass here.
Agree. There is nearly nothing.
Yeah, there is no ground glass here, which is also because the moment you have a ground glass, you have to put the probable UIP pattern. Yeah, I don't see any ground glass here.
Minimal ground glass is also accepted in UIP.
It's acceptable to have a minimal ground glass. The predominant finding is the honeycomb and the bronchiectasis. Yes.
There is no discussion about it. So we agree, despite the report was not associated with ground glass. I think that was not appropriate.
Okay, so let's see the last CT.
To add that this was minimal or non-relevant compared to the reticulation and the honeycombing.
Okay, so let's see the last CT scan.
We'll go now to the CTPA.
Okay. So again, you're seeing this predominant peripheral reticulation sparing the central portion around the mediastinum. Again, you're seeing those 4 quadrant signs. In each subpleural space, in the upper lobes, middle lobes, lingual, lower lobes, you're getting this, subpleural stacks of cysts, which are very consistent with honeycomb. Between them, I can see bronchiectasis because I'm actually able to trace that bronchus as he goes all the way down. This one has a little bit more, there is more severe disease at the apices, but UIP as it progresses, it's gonna keep building up those cystic structure. Now here, actually, if you look at the images, somebody might actually be fooled of saying that there are some ground glass changes. But remember, those people, they're actually dyspneic most of the time. When you put them on their back, they're gonna actually become even more dyspneic, and so that's why they are breathing at some point. Because our optimal imaging is basically to have them at end inspiration while they breathe. While we scan. So if he cannot or she cannot tolerate that, expiratory atelectasis or ground glass is gonna start showing on the CT, and that's something we usually it's a confounding factor, but again the distribution and the pattern is a UIP, typical UIP pattern here in this case as well.
I have something to add. So we all agree there is no ground glass. The radiologists went further on and measured the density of the lung parenchyma who was not involved by honeycombing. And he reported that density is usually higher than expected. And
sorry, I lost you. I lost your voice for 1 second. What was the density?
Unusually higher.
So so we don't usually measure lung attenuation densities because the Hounsfield for the lung can go between -800 and -1010. You're talking about air which is supposed to be dark. Now, again, if the patient breathes out a little bit, you're gonna falsely increase the attenuation of the lung. If you put the patient prone and you move the blood to the dependent portions of the lung, the dependent portion of the lung will look brighter than the back of the lung. So if you actually play with the window setting, I can actually make the lung completely, loaded with pulmonary edema. So measuring densities has never been, validated by any research or data criteria I'm aware of. It doesn't tell me anything.
This was also my impression, but I go further with the presentation. And
sure.
So the question I have is, first of all, does professional UIP exist or not? So what we know is if we take diagnosed IPF, not
Dr. Fabrizio, we have 4 minutes.
Okay, let's finish for me.
Okay.
If we have diagnosed IPF, the exposure counts in terms of survival. If we what else? The type of exposure counts in terms of survival. So, for example, diesel doesn't affect as the wood, for example. And we know also that it matters in terms of early onset and longer duration of the symptoms. I remember that we are discussing about a dentist who's exposed throughout his professional life to the dust of their dental matter. So we know nintedanib is effective in IPF and in interstitial lung disease. But should we treat professional IPF, means patients with UIP pattern and non-professional exposure, although it was only reported in one registry as IPF? So this was my question. I know that bleomycin fibrosis can be improved by bone marrow mesenchymal stem cells, tacrolimus, sirolimus. We also know that mycophenolate was used also in IPF with a surprising effect on declining of lung function. And so in this study, for example, they treated IPF either with mycophenolate or with no treatment, or they compare with treatment, detrimental treatment, like azathioprine. And the surprise is non-treatment is worse than anything else. And so we know that also mycophenolate can be associated with an nintedanib, and this is without additional risks. So I think I'm going to bring back this case to the MDT meeting. So I will discuss about the Ctpa findings. I would say that in this case, we need to reconsider the treatment. And my question, which I'm going to put to the MDT once again, is a dentist with an unusual distribution of the honeycombing, with, although we know no evidence of ground glass, but reported high density, which we don't know what it means. Shall we treat him differently? And thank you.
Thank you, Dr. Fabrizio. So, Dr. Fabrizio, one question. Was there an option of doing bronchoscopy? Was there any option to do bronchoscopy just to see if a patient having lymphocytic, for example, given the fact that he has higher or upper loop honeycombing, whether a patient has hypersensitive pneumonitis?
Yes.
Secondary to dust exposure.
First of all, the patient is extremely breathless, and they saturated in the second minute when he was on 1 liter of oxygen, and in the third minute on 6 liters of oxygen. So a bronchoalveolar lavage is potentially dangerous, very dangerous. So I didn't think about it because of this reason. And obviously no other a surgical option of biopsy can be considered. Anyway, even in this case, we would go against the guidelines where UIP pattern doesn't require a biopsy, doesn't require bronchoalveolar lavage.
Exactly. And plus another thing also, it's the CT is mainly fibrotic. So we have antifibrotic and anti-inflammatory. So mycophenolate will act more as an anti-inflammatory, although like some of the connective tissue disease, like rheumatoid arthritis, UIP pattern, some of the studies showed that in RA, UIP, their anti-inflammatory can have a role as well.
So in my opinion, I'm not sure 100% is the fibrosis we see is reversible or not. I showed you 2 examples where mycophenolate and other anti-immunosuppressants are effective in changing the fibrosis. For example, bleomycin-induced lung fibrosis. So we are dealing here with an IPF which has exposure to dust and profession. So the question is it IPF or is it something else that might respond to the microphone?
Okay, That's interesting. I think biopsy as well will help in the differentiating, but I mean, given the fact that he's in high oxygen and he's hypoxic, will be risky as well. Okay, let's see if there is any question. I cannot see any question. Okay, let me see. Okay, there's some questions.
Sorry, you know, so in the Q&A, there were a few questions. Sorry, Sharina.
Yeah, I found that. Do you want to go over the question or shall we keep it at the end? Because we have 4 questions.
That's fine. We can go at the end. That's okay.
Okay.
All right.
So I think maybe it will be useful to discuss each, questions after of each case. What do you think?
No, that's okay. I mean, I think we had a pretty good discussion about this topic. The questions that we have right now, the one relevant to this topic is a question regarding the early treatment of IPF. The question was that if you have someone with an FVC of 80%, I believe there was a typo in the beginning. The question asked was if there was a FVC of 50%.
50%. Oh, yeah, that's a fun.
Yeah. And so the question really is if we have a FVC of 80% predicted, should you start treatment then? Fabrizio, you want to answer that?
You mean if I would start the treatment? Once I have the diagnosis, I would start the treatment, yes. And the discussion was in the MDT meeting. In the MDT meeting, the decision was that this is IPF, and we should treat it as IPF. And I'm going back to the function. In this case, was 50%, if I recall. Let me see. There you are. So 51%. But even if it was preserved function, I would have started the nintedanib with the diagnosis of IPF. And the MDT meeting found enough evidence to say that there was no need for further biopsy or inflammation.
And so, you know, to answer the specific question about starting treatment at 80%, you know, at 80%, you can certainly hold off on treatment because we know the majority cases of UIP are progressive in nature. These patients should still have a biannual follow-up with pulmonary function testing at least. And if there is a 12-month decline of greater than 10% in the first vital capacity, we should definitely start treatment. So even if you're at 70%, within a year or so, you should start treatment. So that is to answer the specific question.
Okay, and then the second question about the combination therapy of pirfenidone and nintedanib with patients with IPF who have deterioration on one drug. So apparently the study has done that combination are better tolerated, but there's no study saying that pirfenidone and nintedanib combining have better effects in terms of like progression, decrease of progression. The study which was done, it was assessing the tolerability and the side effect.
Exactly. So we've established the adverse side effect and the tolerability of the two drugs together. The patients in which these drugs were trialed were all advanced patients. So we know that beyond a certain point, the decline is always precipitous. You know, what would be helpful eventually at some point is if we have data on what happens to patients if they're started early on dual agents. That would really be the big clincher. But as of now, there is no downside of starting dual treatment. These patients just have to be monitored carefully for tolerability and adverse effects.
Okay. So on the third question about antibiotic, the use of antibiotic in COVID-19 fibrosis, few cases reported have been published. Do you think that it is a treatment which should be considered? And has anyone used, any of us used it? Is that antifibrotic maybe, I think? I think antifibrotic. There are some cases, and I mean, some even study what was published about the use of antifibrotic, and even some of the studies assessing that that those patients post-viral, post-COVID infection, they developed IPS, picture of IPF eventually. But there was also a study about the antifibrotic, but I haven't tried it yet.
So, you know, again, that's all observational data. So there is a tremendous body of literature available on patients who had massive radiographic changes and then who really progressed to a normal recovery clinically and radiologically. And, you know, that's similar to some influenza pneumonias that we see as well. So as an international community, we're still struggling to call what the immediate post-infectious time period is and when to decide when this is actually a fibrotic process of disease. And then secondly, we have to decide if this is even treatment amenable to our current antifibrotic agents. So as of now, in the absence of any more data, if you have patients who are struggling with severe fibrosis, who you feel are going to be headed to transplant in the next few years anyway, there is no harm in trying antifibrotics. But the hope is that this is not going to be progressive fibrotic disease in this post-viral entity that we're looking at. Yes, Fabrizio.
Fabrizio.
Oh.
Go ahead.
Yeah, can I add something?
Yes.
So, you know, we've actually collecting cases since we've seen lots of post-COVID fibrosis, and we've been following them up by imaging. So the most thing that, you know, about one common thing about those post-COVID fibrosis, they come with organizing pneumonia, and then the organizing pneumonia cause some fibrosis with architectural distortion at the periphery. However, at least now we have at least 4 or 5 cases that we've been like following them up by serial chest CT scan examinations, maybe every 2 to 3 months. I do not remember if they are in any like steroids or anything like this, but I can tell you from from imaging, we are seeing that those, you know, so-called fibrosis that we thought that they're going to become permanent and irreversible are actually melting down. And they are going back to a more of a ground glass stage, and then they're actually leaving behind some reticulation, which we usually see with lots of post-inflammatory or post-infection, you know, like influenza, as Dr. Khan said. So at first we were debating if we should probably, if our group should start putting them on antifibrotic medication. But I think I think time would tell if we need that or not. So far, they're actually going away by themselves, you know.
Yeah, most of the moderate, even like if you follow the PTS guideline, I try to follow the PTS guideline in those patients post-COVID, and I see them in 1 month and in 2 months. Most of them, like in 1 month, if you see them in 1 month, you find some restriction still in the spirometry. But then in 2 months, 3 months, you will see that like improvement in restriction, and most of moderate patients have seen melted. They have like no fibrotic, remnant fibrotic changes. I agree with you. Yes, Dr. Fabrizio.
Few cases which came to my clinic because of symptomatic post-COVID condition with their significant limitation of the lung diffusion capacity and their restrictive pattern. The patients I treated only the severely symptomatic patients, and they responded very well to steroids. I think stressing the fact that, as Dr. Mahmoud said, is most likely to be secondary OP to the infection. Then the question mark is, if we leave the OP to heal by itself, how many patients will be left with scars? And if we treat only with the steroids, how many patients are left with the scars? I think if there is symptoms and the extension of the fibrosis is significant, I wouldn't risk my patient to remain with large scars in the lung. Especially because I'm talking about 35, 40-year-old gentlemen.
Okay, great, perfect. So let's go to the second case, Dr. Saniya.
Sorry, there we go. All right, everyone. Thank you. That was a great discussion. Thank you, Ashraf and Mahmoud and Fabrizio, because you've made my job easier now. So moving forward, as you know, this evening, the theme of this evening is pulmonary fibrosis and all sorts of pulmonary fibrosis. We'll talk about why it's important to know what the kind of fibrosis it is, where it's coming from, because obviously that means that our patient's prognosis will depend on it. I am trying to, advance my slides. Okay. All right. So I have no financial or industrial disclosures. The objective of my talk today is to obviously identify chronic interstitial pneumonias, particularly fibrotic disease, okay? To understand various etiologies of fibrotic lung disease, understand the workup of idiopathic interstitial pneumonias, which Ashraf went over very nicely, identify patients that require an advanced lung disease center for management, and identify patients that require lung transplantation. So I'm going to start presenting my first case, who is a 56-year-old female who presented to our hospital at CCAD in 2015 with a 10-year history of dry cough. She had visited Thailand and was started on prednisone at 20 milligrams daily, and she's been on and off for it over the last 10 years by the time she arrived to us. She denied any family history of chronic lung disease. She's a non-smoker, uses Bakhur at home, which she had stopped at the time of the initial diagnosis of about 10 years ago. And she also lives with a talking parrot in our house over the last 10 years. Her review of system is positive for dyspnea, cough, decreased exercise capacity, and widespread joint pains. In our physical exam, this is a cheerful middle-aged lady with profound conversational dyspnea, very thin and, sort of looking like someone who has a chronic disease. Despite being on steroids, her face is Cushingoid, but the rest of her was pretty cachectic, sort of highlighting that this is someone in a constant catabolic rate. Tachycardia with tachypnea and saturating 90% on 2 liters. Liters, massive digital clubbing, very tremulous, which we'll often see with people with advanced pulmonary disease, along with 1+ lower extremity edema. Bilateral coarse crackles bilaterally and tachycardia with intact heart sounds. She also had bilateral MP joint swelling and deformity, swelling, tenderness in multiple interphalangeal joints, as well as ulnar deviation at the wrists. Mahmoud, I'll let you take over the radiology for her.
Okay. Can you hear me?
Yeah, these are her initial images with us.
Yeah. So we have 3 images, as you can see. One is cutting through the trachea just before the carina. We have the second image, basically, cutting through the heart. So the predominant findings here are actually, if you look at this and you remember the cases that we just discussed, Dr. Fabrizio's cases, that subpleural cystic changes at the bases are not present here. You're seeing cysts, but actually those cysts are actually in the center of the lung, not at the periphery of the lung. They're actually more pronounced at the center, more on the periphery. And there is also a uniform distribution. So they're not sparing really the center. They're basically all over the place. Here, actually, you can see actually some ground glass changes, some areas of air entrapment, lobular air entrapment, like in the left lung, you can see some in the second image on the top. You can see those like hyperlucency, exactly. So, that is, so basically this is not a UIP, not a typical, not even a probable UIP. That's actually now inconsistent with UIP. And this is basically now we start searching for, the connective tissue diseases, the collagen vascular diseases, the occupational lung diseases, sarcoidosis, and all other, fibrotic lung disease.
So, Dr. Mahmoud, why did you say it's inconsistent? Is that because of the ground glass or because of the cysts?
No. So basically, the ground glass, the cysts, and the lobular air entrapment are actually not features of a UIP. So it's not a typical UIP. So first of all, it's not a typical UIP because you don't have honeycombing. So now you're left between the probable UIP or the inconsistent with UIP. The probable UIP, you don't have honeycomb, but you're going to have a little bit of ground glass and traction. But you shouldn't have air entrapment. Here, actually, if you look in the second image on the top, this one, where actually, yes, the arrow is, there is an area of lobular air entrapment. This is something that sometimes we see mainly with chronic hypersensitivity pneumonitis, but sometimes we also can also see it, in other like connective tissue disease. Now, if you look also, this patient has some cysts. These are not bronchiectasis, and they are in the center of the image. So the moment you are seeing cysts, you have to consider the lymphoproliferative disorders, the LIP pattern, the Langerhans, histocytosis. These are all can present in similar features like this. And of course, the clinical features, the serological features, will take you away from the probable UIP and put you under the inconsistent with UIP.
Is that the pattern? Do we call it Hitches pattern, the one with the entrapment and ground glass?
Yes, actually, this is the Rick Webb's Hitches pattern, right? You've got in the relative areas of normal lung, areas of increased darkness, which is air entrapment and ground glass. Although I would have to say here that the lungs are basically all diseased, so you're missing the normal lung component. Everything else here is between a balance between cysts, ground glass, and air entrapment.
Thank you very much. So that's a very important point, which I want all of you to remember, that you don't really see normal lung tissue interspersed here. Radiographically, you see a heterogeneous mixture of cysts, fibrotic area, ground glass area, and traction bronchiectasis area. So moving on with this patient's first pulmonary function test in 2015 showed severe restriction with a reduction in the forced vital capacity in the 30s, along with a total lung capacity, which was also down to the 30s, and along with a concomitant reduction in the residual volume. We were never really able to do a good diffusion capacity on her because she was so breathless. The 6-minute walk test, as you can see, started with 94% on room air, which at about the walking distance of really just about 118 meters, we have her desaturating down to 81% on 1 liter nasal cannula, eventually finishing at 1250, requiring 8 liters of oxygen, still desaturating down to 86%. Her labs at this time revealed that she had a normal, let me go over the labs first. So a rheumatoid factor was pretty high at 16 with a very high anti-CCP titer of 212. The remaining ANA and ENA titers were negative. ESR was elevated, and a CRP TB quant were negative, which is relevant for her. A hypersensitivity pneumonitis panel just revealed positive antibody to pigeon, which is neither here or there for her. The echocardiogram revealed mostly a normal hyperdynamic left ventricle with stage 1 diastolic dysfunction, and a right heart cath was done to confirm this right ventricular systolic pressure of 60 millimeters, revealing a mean PA arterial pressure of about 45 with a normal capillary wedge pressure, which is consistent with mild pulmonary hypertension. A bronchoscopy was done on her, which was undiagnostic. At this time, I'm going to ask you a question. This is an audience response question. If you can see at the bottom of your screen, there should be a button which indicates polling. Please go ahead and use that button for the response. Can you guys see the polling button? You can. All right. So our question is, of course, at this time, the following steps should be performed. A, surgical lung biopsy. B, discussion and MDT plus minus referral to an ILD center. C, repeat bronchoscopic biopsy. D, a second opinion of the bronchoscopic biopsy pathology that was inconclusive. We have a fantastic quorum here today, so I'm hoping we'll be able to have a good discussion here. Right, so we will end our poll, and the majority of you answered what is the correct answer, which is discussion in an MDT center and a referral to an ILD center. We'll go over the options of why a biopsy option, whether it's a surgical or a repeat bronchoscopic biopsy, is not helpful. Well, first of all, bear in mind for a surgical lung biopsy, this patient has severe restrictive disease and a diffusion capacity, which is down to now in the 40%. Now, these patients have a very high mortality for surgical lung biopsy. Also, we see in this radiograph, this is mostly extensive fibrotic disease of all sorts. So apart from finding just exactly that on the biopsy, we're not really going to have anything different. And lastly, second biopsy, a second opinion of this is, again, remember in such a fibrotic lung, the reason why the biopsy is unhelpful is because you're just seeing indiscriminate fibrosis, which we can see also on the radiographs. For this patient, particularly, the bronchoalveolar lavage was pretty bland. It was lymphocytic in origin, along with neutrophils. So this for her is neither here or there in making the diagnosis. Oh, so sorry, I'm trying to shut this. So basically what we know after our ALD meeting, that this is a fibrotic disease spectrum, okay? So certainly with her clinical examination and the elevated rheumatoid and CCP, we know that there is probably a component of rheumatoid arthritis pulmonary fibrosis. There may as well be a component of chronic hypersensitivity pneumonitis. We had the radiographic features of it. And then secondly, we had a parrot that she was living with for 10 years. It could be idiopathic pulmonary fibrosis. And of course, an overlap interstitial lung disease is possible as well. So our treatment for this patient, we started mycophenolate and we escalated it to 2 grams daily. And we worked on decreasing her prednisone dose and we maintained it between 2.5 to 10 milligrams daily. We did refer her to rheumatology. She did have full-blown rheumatoid arthritis with multiple joint involvements in the body. Leflunomide was added to her regimen. And the goal of the prednisone to keep this at the lower end was also really for her joints, not so much for her lungs. Fosfomax for osteoporosis was started on her because she had been on steroids for approximately 10 years, and then oral hypoglycemics were also introduced for steroid-induced diabetes mellitus. We started pirfenidone in her in 2017 at 800 milligram 3 times a day, and then she was listed and worked up for lung transplantation. So we're going to talk a little bit about rheumatoid arthritis associated with pulmonary fibrosis. Now, ILD is the commonest manifestation of rheumatoid lung disease. And all areas of the lung can be involved with RA-ILD. Sorry, I'm just going to minimize this, sorry. As we know, there are multiple manifestations of multiple pulmonary manifestations in rheumatoid arthritis, but ILD is the commonest manifestation. Rheumatoid arthritis, ILD, and infections are the most common causes of pulmonary involvement. It occurs in up to 10% of the RA population, though in autopsy patients of rheumatoid arthritis, they found approximately 30% of those samples to have pulmonary involvement. Now, over the years, we have reduced the mortality of rheumatoid arthritis with advancing biologic treatment, and therefore we are finding that in the older population of patients who have survived their rheumatoid arthritis are actually manifesting their interstitial lung disease more. The commonest histopathology in rheumatoid arthritis is usual interstitial pneumonia and NSIP, and other ILD variants can be seen as well. Overlap features of more than one histopathology can also be seen. So for example, in one patient, you can see features of both UIP and NSIP. And a very big difference in the fibrosis that we see in rheumatoid arthritis and classic UIP is the presence of fewer fibroblastic foci. The risk factor for RA-UIP is particularly high titers of rheumatoid arthritis, as we saw, a rheumatoid factor, as we saw in this patient. You'll see it in men. Men will have the disease greater than women. Erosive joint disease with articular symptoms are usually going to precede the pulmonary symptoms, and that is mostly true for all the RA-ILD patients that we've seen. A high titer of anti-CCP is also seen in these patients, though specifically there is the antibody to citrulinated HSP90, which is a subtype of the anti-CCP antibody, which we see in the rheumatoid arthritis ILD. This is more for academic interest. We don't really measure it clinically. A prior history of smoking puts you in the high risk category. And in other predisposing factors, the presence of the mucin 5B promoter variant, that is a genetic predominance seen in these patients. And the accumulation of this disrupts the repair mechanisms or interferes with the ciliary clearance in the lungs. And this particular variant, the MUC5B promoter variant, is actually not seen commonly in the ILD or pulmonary fibrosis seen in scleroderma or inflammatory myositis. So that's an interesting thing, that we find this variant mostly in the rheumatoid population. Ariali evaluation is no different than any other ILD evaluation. Your clinical features are going to be typical chronic respiratory symptoms of cough, dyspnea, and dyspnea on exertion. Our pulmonary function test will reveal restriction and diffusion defects. Our high resolution CT scan is one of the initial places to start your workup. An important part in these patients is obviously to rule out infections, particularly if they're on biologic agents. Iatrogenic lung toxicities, now nearly all the biologic agents that we have the potential for pulmonary toxicity. I'm going to spend about 30 seconds on this, because just remember that a lot of times we as pulmonologists, even as ILD pulmonologists, were hesitant to start some new treatments, whether it's rheumatoid arthritis ILD or sarcoidosis, etc., because of the fear of further exacerbating interstitial lung disease. One common agent as such is methotrexate, for example. But what we do know now from bigger data sets, that the iatrogenic lung toxicity, particularly from the agents similar to methotrexate, is less than 3%. So therefore, if we feel that any of these agents are still the top choice of the first, should be the first line of treatment for these patients, we should still go ahead with that. And then last but not least, heart failure is an important thing to rule out, particularly as in this patient, there is mild pulmonary hypertension with diastolic dysfunction. Her lower extremity edema suggests that she is a tad bit volume overloaded, more than her heart can handle. The ESR and CRP correlate better with the rheumatoid joint disease. Okay, this patient's ESR was elevated upon arrival, and we did follow it through over the years, and that had to do more with her articular disease, not so much with her pulmonary disease. Bronchoscopic evaluation is not considered a routine part in the diagnosis of rheumatoid arthritis ILD. In general, just as caveats, you will see symptomatic RA-ILD. If you do a bronchoscopic lavage, you will see that there is a predominance of neutrophils and occasional eosinophils. If there is subclinical asymptomatic disease, you will generally see a bland or a lymphocytic predominant lavage. The main role of bronchoscopy is really to rule out infections. The treatment of RA-UIP really depends on what underlying what is the overall picture of the patient. So, what is the prognosis of the patient? What is the likelihood of response to therapy? What do you feel are the potential benefits of early therapy? And the optimal treatment for any rheumatoid arthritis ILD is derived from what we think is the underlying primary pulmonary disease. The patient should be managed or at least consult or co-manage with an advanced lung disease center with multidisciplinary involvement. Asymptomatic patients, those with mild rheumatoid arthritis ILD, should at least be monitored with biannual PFTs. The conversion to fibrotic disease should be carefully monitored. Treatment can be initiated with prednisone up to 0.5 milligram per kg per day, with a max dose of 60 milligrams, and that should be de-escalated for over 3 months. However, if you are seeing something which is purely fibrotic, minus any real articular symptom, we err on the side of keeping the steroid dose low. The preference is to move faster to steroid-sparing treatment, which can be Imuran, mycophenolate, and IV cyclophosphamide. Mycophenolate currently holds favor because of observed stability and improvement in pulmonary physiology with good tolerance and low side effect profile. And this we have actually studied in various connective tissue diseases now. And I would recommend that as the first treatment of choice in these patients. Now, nintedanib should be particularly considered for patients with fibrotic disease, even if it is a non-UIP pattern of disease, whether it's fibrosing NSIP also, or an indiscriminate fibrotic pattern of disease. A large cohort was presented by the North American Michigan Pulmonary Fibrosis Group from the University of Michigan, Ann Arbor, and they did report results similar to the scleroderma studies with the retardation of the forced vital capacity decline by over 50 cc's per year. And so that is something that we should carefully consider at the time of treatment. So we have our second question now. This is also audience response. And so for the management of patients with advanced fibrotic disease, all the following management steps are recommended, except. Your time started now. Go ahead, please. So this poll appears distributed across the board. So when you go in question writing workshops and when you get such an answer, usually they tell us that your question might be bad. So I won't hold all of you responsible for being confused. So what the correct answer for this is, because it's an accept question, is the initiation of high doses. The question is, in a patient with advanced fibrotic disease, what would you do except? So initiation of antifibrotic agents, we just talked about. We do consider now initiation of antifibrotic agents because there's really not any place to go for these patients. We have data to suggest that there is a retardation in the forced vital capacity decline, and therefore initiation of antifibrotics is a good idea. Initiation of high-dose steroids, particularly in an advanced fibrotic disease. Now, problem with that is just the patient that I described to you right now is going to be your typical patient with advanced fibrotic disease. With a little bit of pulmonary hypertension, a little bit of diastolic dysfunction, a little bit of lower extremity edema. And these patients can actually get tipped over with high-dose steroids very easily. And so a lot of these patients who come in our system actually land in our intensive care unit because they're volume overloaded with fulminant acute or chronic hypoxic respiratory failure. So I would advise against initiation of high-dose steroids in these patients. If you really feel hard-pressed to do steroids, the way to go would be to do lower-dose steroids. Now, workup for lung transplantation, certainly, and workup for pulmonary rehabilitation. Now, that is a very big part in the management of these patients, one that we don't talk about very often. You know, if you're sending someone for a lung transplantation, there are many comorbid, premorbid factors that will, in the end, help qualify these patients for transplantation and also help them do well after transplantation. And one of them is their functional capacity. And therefore, pulmonary rehabilitation is an important part in the management of these patients. That and nutrition, because we do know that the mortality is higher in patients with a BMI of below 20 and a BMI of above 50. So both these two extremes don't do very well for transplantation. So our patient was listed for lung transplant and she was continued on mycophenolate at full doses for 5 years. And she was also maintained on leflunomide for rheumatoid arthritis. As I told you before, she was started on pirfenidone in 2017, and it was stopped after a year because she continued to have GI disturbances and weight loss. As it is, she was underweight, and we didn't want her to lose more weight on pirfenidone treatment. She was started on nintedanib 100 milligram BID. One would question why I started 100 and not 150. That was really to see if she would tolerate it or not. If her weight would increase with this dose and that she wouldn't have diarrhea and all. She tolerated it well and then developed localized first dose ischemia. And at that time, the concern was certainly that this was because of the nintedanib. We know that large vessel occlusions, there is a higher incidence of acute coronary syndrome and strokes on nintedanib. her medication was stopped and she underwent vascular studies. This was important because she was still being considered for transplantation, and we don't want her to be considered a poor candidate for nintedanib because that may be applicable for her in the future as well. So her vascular studies were intact and therefore treatment was restarted and she did fine. In December 2019, she underwent bilateral sequential lung transplantation at CCAD. And I will go through the explanted lung pathology. Now this right here, if you look at the top screen, this is her pathology. This is a subpleural image. Those large cystic lesions that Mahmoud was talking about, they just, you can see them as these large destroyed spaces right here in the pathology as well. In the high magnification field, you will see that there is these are the fibroblastic foci right here. And the difference between this patient's fibroblastic presence and in a patient with UIP was that these foci were very little. And that sort of goes against a typical UIP pattern of disease. Also, if you see on the right-hand side, we have a normal lung. Just for reference, these are the thin single cell, what do you call it? What's the word? Alveolar capillary wall right here, which is a very clean area right here. And you see here, this is this patient's interstitium, which is pretty broad, and it is expanded throughout uniformly with chronic inflammatory cells. Now, as Mahmoud had mentioned in the radiology, in a typical UIP pattern, you will have affected areas with honeycombing, fibrotic changes, interspersed with normal area of lung. In the radiographs for this patient, we didn't see any normal area of lung. And we saw the same thing on pathology as well, that there was no normal area. The entire interstitium was expanded. And again, this sort of goes against typical UIP pattern of disease. So overall, this was consistent with a chronic inflammatory interstitial pneumonia with the absence of granulomas and giant cells. Why I bring up the importance of granulomas, because one of the considered differential diagnosis for her was hypersensitivity pneumonitis, which now we feel she doesn't have in the absence.
You have 3 minutes?
I have 3 minutes. And so this is her post-transplant CT, which Mahmoud can share with us. Mahmoud can talk about.
So again, we've got 3 images. I mean, clearly, with the exception of some discoid atelectasis at the bases and a trace amount of pleural effusion, that is a normal-looking lung without any signs of interstitial lung disease.
Okay. All right. And at this time, I think we still have 2 minutes left. We can take questions, I think. Sharina, if you think that's suitable.
Okay, so let's go over the question. So the first question was about the cost and eligibility of the insurance. Is a big obstacle in starting antifibrotic in eligible patient. Many of my patients could not get medication due to above mentioned reason. How should we counsel them? So what's the issue?
This is a universal problem. This is not a problem that is only a problem in the UAE. This is a problem in North America. This is a problem in Canada. This is a problem in the United Kingdom. Those areas, in fact, are a lot more stringent about the dispensing of these medications, even when they have insurance, because the guidelines which we expand based on studies have not been expanded by the official bodies. So what we then have to do as physicians is we have to be creative. And one of the things really which I find useful in this part of the world is to get alternative treatments from other countries. And that really is about the only thing we can advise. And that's the sad reality of medicine. It doesn't only hold true for pulmonary fibrosis, but it holds true for advanced cancer treatments, for biologic agents, for different things, for rituximab. It holds true for many agents. So it's not just.
So is there any available alternative here in UAE, or should be?
Not yet. No, we don't. We don't have any generic. We actually discouraged a generic for both these agents because in a few of the generics that we have tried from India, I can tell you for certain that the side effect profile behaves a little differently, and really there is no study for efficacy. So I don't know what to tell these patients when they're taking these medications. Yeah.
Okay. So I think the second question, we already discussed that about the antifibrotic therapy and patients with COVID. We are seeing patients significant number of COVID-associated fibrosis, particularly organized pneumonia pattern, who does not respond to steroid, but some cases are UIP pattern, non-responded to steroid. Have you used antifibrotic in these cases? Have you tried antifibrotic? Myself, I haven't tried any antifibrotic in those patients. How about you, Sonia?
No, we haven't. Like we said, as Mahmoud had just mentioned, that right now we are following series of patients, a lot of whom are recovering, and that's our experience with the influenza population as well. So as of now, no, we have not come to the point where we felt strongly about giving antifibrotics to anyone.
Okay. So the third question is to Dr. Mahmoud. Is there any typical CT finding which favor connective tissue disease UIP over IPF UIP? That's an interesting question.
So the connective tissue disease usually have a more of an NSIP picture rather than a UIP picture, with the exception of rheumatoid, which, as Dr. Khan said, it's UIP but also NSIP. So when you talk about dermatomyositis, mixed connective tissue disease, they're all NSIP. So the NSIP, non-specific interstitial pneumonia, they have a different distribution than the UIP. True, they are in the lower lobes as well, but they have a peribronchial vascular distribution, and there's a subpleural sparing, which is basically the opposite of a UIP. UIP starts at the pleural base and goes inward. The NSIP starts in the central portion of the lung and goes towards the periphery.
And there's also anterior segment sign, something, or there's other sign. Anterior sign.
So there are so many signs, but I would like to emphasize the fact that I'm basically probably the only radiologist in the pulmonary group, which is, I think it's an honor for me. But if you do not approach your radiologist and vice versa through meetings or like by phone conversations or by whatever communication, it will hurt the patient. That's why we are very keen about meeting every week to discuss these challenging cases. And sometimes, I might say it's a UIP picture, but the pathology would say it's an HP picture. Disagreements can happen. There is a disconcordancy between pathology and radiology, but it helps us all advance. From an academic perspective, we're all still, we learn from these mistakes. And so that's why we have to do this in an MDT atmosphere.
Okay, great. So the last question is about, with the cystic changes, should LIP be one of the main differential lymphocytic interstitial pneumonia?
Okay. So the cystic lung disease, if you think about LIP in a sense, where is the interstitial component to it? That's why right now the LIP is probably going to move into a separate category. It's going to go under the lymphoproliferative disorders, which is basically ranges from lymphoid, nodular hyperplasia, manifesting as some solid nodules, all the way to lymphoma in the lung. And the spectrum will include LIP-like pictures, So the cysts actually, apparently right now, the pathology is completely different. To have an LIP, the only feature that you should see in that lung parenchyma is cysts with a small vessel running on top of them, like a perivascular cyst. You shouldn't see bronchiectasis, you shouldn't see honeycombing, you shouldn't see ground glass. the finding is basically it's a cystic lung disease. This is where you consider LIP as a, that's why, you know, with the cystic lung disease, you've got the LIP, you've got Langerhans alistocytosis, you've got lymphangiomyomatosis, the LAM, Bird-Hogg-Dubé syndrome. So as I said, these probably, the LIP will probably be moving out of the interstitial lung disease, you know, family.
Okay, thank you, Dr. Mahmoud. So let's go to the last case, Dr. Sonia.
All right, we'll move on to our next talk. The flaw lies not in our stars, but in our genes. I have no financial or industrial exposures, and the objective of this study, of this talk, is to identify presence of underlying chronic diseases, particularly interstitial lung diseases, especially when you're thinking atypical pulmonary fibrosis or atypical ILD, and to understand some genetic basis of pulmonary fibrosis. So our case is a 41-year-old female of Indian origin who presented to us in 2015 with a diagnosis of asthma. She complained of dyspnea on exertion since 2011 and had been on treatment for asthma as well, with really no symptom improvement. Her review of symptoms was positive for fatigue, malaise, and respiratory symptoms. In our physical examination, this was a young woman with stable vitals and normal weight, no distress. She had bilateral digital clubbing and bilateral coarse crackles on examination. This takes us to our next audience response question. At this time, the following information is most important: a history of environmental exposures, the age of onset of the disease, family history for lung diseases, family history for systemic diseases, or E, all of the above. Okay, so I think we have quite a bit of answers. So most of you got the correct answer that all of the above is important. Now remember, this is a young patient who is 45 right now, gives a 10-year history approximately of symptoms. So therefore, probably in the mid-30s, whatever process she has had started. And in these kind of patients, we really have to go as deep as we can in trying to find the information on what could be the cause. So the combination of environmental, age of onset, family history of all sorts is important. So the important part in her is that her brother was a resident in Singapore and had some lung disease which had required lung transplantation. And this brother was in his late 30s when this transplant had happened. She denied any other significant environmental and occupational exposure. She was a housewife. She is a housewife. And of course, the differential diagnosis in this patient, before we even look further, is an interstitial lung disease of some sort, a fibrotic lung disease of some sort, particularly because of the chronicity of disease and the presence of significant clubbing. And of course, because of her brother's history, a familial fibrotic lung disease is on the cards. So moderate restrictive disease on spirometry with the diffusion in 2012, that was her first diffusion capacity ever done, was at 40%. So a moderately severe reduction in the diffusion capacity. All her labs were within normal limits, including her connective tissue disease profile. A 6-minute walk test revealed no desaturation, and her walking distance was also intact. And her echocardiogram to date has been within normal limits. Mahmoud, if you can take over the radiology in this patient.
Okay. So we've got 4 axial images in the lung window setting. So if you look at these images, I would say the predominant findings here are 2 things. We've got cysts of variable sizes. They are not emphysematous like cysts, because, you know, with emphysema, you shouldn't see a wall, and you should see some, like the central lobular artery inside those, you know, emphysema. These are really like, you know, concrete, well-defined cysts with like nice membrane to them. And there's also the coarse reticulation that is seen, again, diffusely scattered, random, asymmetric, you know, not a honeycomb, not a UIP. So now we're dealing with a mixture of a cystic lung disease and interstitial lung disease. The weird thing about this case is basically it doesn't fulfill any of the, you know, the UIP, the NSIP. you notice that the lung disease are mainly in the APCs, not in the bases. The bases are actually relatively spared. There is some reticulation at the base, but these are completely insignificant. So now we start thinking about things like, could this be a chronic HP? Could this patient be exposed to something, when she was young? That's one. Two, we have to consider also, the history that there might be an underlying genetical syndrome that is, predisposing her to these changes. As a pediatric radiologist as well, I do see these, in less than 18 years of age with people who has surfactant deficiencies, on high oxygen level, they change to BPD with advances in, management. We are seeing those survive to the, adulthood. So some underlying disease should be, we should consider that. Certainly some, immune deficiencies, things can actually also cause cystic destruction of the lung.
Great. So meanwhile, we got the explanted pneumonectomy pathology of the patient's brother, and that revealed chronic interstitial pneumonia with really large areas of honeycombing. Classic features of UIP were absent, and they thought perhaps because of the advanced stage of disease. There was an unusually high amount of lymphocytes and plasma cells with a lot of superimposed acute lung injury. There were multiple foci of ulceration in the bronchiolar epithelium, and there was no evidence of granulomatous disease and neither of any microorganisms. So all in all, you can see that this is a pretty widespread diffuse end-stage chronic interstitial pneumonia, which had progressed to fibrotic disease in no real discriminate pattern. So we'll talk a little bit about our genetic syndromes with pulmonary fibrosis. This is a complicated issue, but I'm going to try and keep this as simple as possible. We're going to look at three main categories. One is the familial pulmonary fibrosis. So in all of the IPF cases, they account for less than 5%. And the three main genotypes that we look at, the varied surfactant-associated protein, which is the SFTPA2, the surfactant protein SFTPC, and the mucin 5B, which is the MUC5B. So these are part of the familiar pulmonary syndrome spectrum. Second is the Hermansky-Pudlak syndrome, which is an autosomal recessive. So we'll talk a little bit more about the familial fibrosis, but I'm just going to give you a little overview of some other syndromes. Hermansky-Pudlak, as you know, is a conglomerate of symptoms, which is autosomal recessive with platelet disorders and oculocutaneous albinism, with early IPF, mostly seen in patients before the 4th decade of life. The largest study groups in Hermansky-Pudlak actually comes from the Puerto Rican population, and those patients do have some varied degree of pigmentation in their hair and skin. And then we have the telomeropathies. Now, short telomeres are seen in 25% of the genotypes of IPF and in 15% of familial pulmonary fibrosis. We'll talk a little bit more about this because combined with the telomeropathies are the short telomere syndrome, where you have severely short telomeres, having not only pulmonary disease, but they may have one or more organ dysfunction, particularly bone marrow, liver, skin, and lungs. Examples of these are the TERT, TERK, PARN, DKC1, TINF2, and RTL10. So when in the first question that we asked, we talked about a family history of pulmonary disease, but a family history of systemic disease. So a lot of these patients are going to have issues in the bone marrow. So for example, these patients will have either a single cell line dysfunction or aplastic anemia. They can have premature liver failure, liver cirrhosis, transaminitis, and then certainly pulmonary fibrosis that happens prematurely. There's various syndromes. The most common one that you'll always hear about is the dyskeratosis congenita, which is, again, a spectrum of disorders. Familial pulmonary fibrosis is defined particularly as an idiopathic interstitial pneumonia in 2 or more first-degree relatives, okay? So a parent, siblings, And up to 20% of cases of IIP clusters in families, actually. Some, but not all mutations are known for this entity, and IPF is still the most common form of familial interstitial pneumonia in about 55% of patients, and 45% of these can be heterogeneous for other subtypes. And interestingly, to the point where you can have a single genotype in a family, and various family members will have a different phenotype from a pulmonary standpoint also. So some of them can have UIP, and some of them can have a completely different form of interstitial pneumonia. The age of onset of these patients is typically between age 50 to 70 years. Now, for some genes, for example, the surfactant, the SFTPC gene, the age at diagnosis can actually be from infancy to young adulthood. Even within the family, this gene, if this gene is present, you can have some family members that are showing in infancy and some that manifest in the late adulthood. Common symptoms, of course, are dyspnea and exertion, dry cough, and clubbing. A lot of these patients will have other systemic symptoms of fevers, weight loss, fatigue, muscle and joint pains, all of which are sort of signs of catabolic states and of a body being constantly under stress. Physical examination and PFT data mimics other interstitial pneumonias. Now, the rate of progression of disease varies amongst patients. So no two patients, even within the same family, having the same genotype, are similar in their presentation as well as in their pattern of the course of disease. Therefore, careful longitudinal monitoring is recommended in all known cases. The course ranges from progressive decline to acute rapid decompensation. And the familial pulmonary fibrosis variant may actually be complicated by lung cancer. We'll talk about that. So like I said, at least one, the definition is at least one or more than one first-degree relatives. And then you can seal that diagnosis if you have a pathogenic variant identified on molecular genetic testing. The commonest are these four that I have over here for you: the TERT, which are telomeropathies, and the SFTPC and SFTPA2 are the surfactant protein anomalies, with the TERT accounting for approximately 18% of mutations in the familial cases. TERT is less than 1%. SFTPC is up to 25%, and the SFTPA2 is, again, approximately 1% of cases. The pathogenic variants in these cases, as I said, are about 8 to 15% in the familial cases. And even in 1 to 3% of cases, in simplex cases, the simplex is the occurrence of this mutation as a single occurrence in a family. The variants, 1 to 3% are still these same genes that we're talking about. Now, inheritance in these patients of these genotypes is complex, and I'll tell you why that's important. It is normally autosomal dominance with or without reduced penetrance, with there some possibility of an autosomal recessive inheritance as well. Now, prenatal diagnosis is possible, but the positive predictive value is unclear. And therefore, that puts into question about genetic testing in these patients, like what the value of genetic testing in these patients is ethically still questionable, because we don't know which of these patients are going to eventually declare to a diseased phenotype. Approaches to genetic testing include serial gene testing, where you have identified a gene in a family and you, with the pertinent family history of age of onset, presence or absence of lung cancers, etc., you can identify a specific gene and target that. The SFTPA2 family is actually described to have bronchoalveolar carcinoma and adenocarcinoma lung. And like I said, the SFTPC are earlier onset of disease. TERT and TERC account for majority, but they may or may not have clinical features of telomerase syndrome, which we talked about. Those are separate features. The multivariate analysis is where you do the whole panel, okay? And that is, again, fraught with complications because the genes included in the panel and the diagnostic sensitivity of testing varies in each center. And therefore, clinicians need to be able to identify what a good panel is, what genetic lab they trust, and what would work better based upon the phenotype of their patients. So in our patients, what happened was in 2018, she came with her mother who resides in Canada with her son. And there she'd had a severe respiratory illness after contracting influenza, requiring BiPAP with ICU stay. She otherwise denied having ever any respiratory symptoms. And currently she continued to have some dyspnea on exertion. The mother was in her mid-50s at the time of her presentation to us. And this, Mahmoud, is her mother's scan. Go ahead, please.
Yes. So again, 3 images. This is the mother. So she also have some cysts and some reticulation, also like similar to the daughter, but very, I would say this is a milder presentation. The daughter has definitely more advanced disease than the mother.
Okay. And I think what's interesting, again, we have a great retrospectogram on this patient, that there are these areas of some cystic presence that we can see. And again, at that time, not really sure what to make of this, because also she had had a severe influenza infection. Mahmoud, would you agree that a post-infectious bullous transformation?
Yeah. Post-infectious pneumatoceles are common in influenza, Staph aureus, and other like bugs. Yeah, absolutely. Definitely, I would not disagree with this.
Yeah. So we know that for this patient, there is a brother who is ill and mom may have something. So the question is, what do we do at this time? And I will ask for your opinion on the matter, that to reach helpful diagnosis for this patient, what is important at this time? An extended family history of lung disease in this family, chest radiographs of the brother, surgical lung biopsy of the patient, or a surgical lung biopsy of the mother. So we have pretty much a half and half distribution about what to do. The correct answer is to get an extended family history of lung disease in this family, now that we've identified that a mother may be involved as well. Now, why the other things don't work? So a chest radiograph of the brother, that at this point is moot, because we have a pathology which showed extensive interstitial pneumonia with fibrotic disease and end-stage destruction. So, a radiograph would not really add more value. A surgical lung biopsy of the patient is probably not helpful at this point, because we have some data that is suggestive that this is a familial pattern of fibrosis. Important things are, these are 2 young individuals, both of which started their manifestation in the early 30s, a brother who was already transplanted in the 30s, and the sister probably has something along the same spectrum. So the only time I would think of doing a surgical lung biopsy of this patient was if we were really considering a cystic lung disease diagnosis of, say, a Langerhans histiocytosis, for example. And that is not the case in this patient. A surgical lung biopsy of the mother is also not done for the same reason. A, she is in her mid-50s, has survived a severe influenza infection and is doing relatively okay right now. And her biopsy will not add any value to our original patient's diagnosis. So moving on. So this is the family history that we got. So if you look on the left side, we have our patient's mother now, okay, who we consider an affected female, and she has a daughter who is an affected female and a son who is definitely affected. Now, why this was important was because in the mother's maternal sister, okay, on the patient's maternal aunt side, there is a grandchild who has been diagnosed with pulmonary fibrosis at 9 months of age, okay? So this is probably where this is probably a maternal side that is carrying this gene, and it is probably the SFTPA4 gene, which, like we said, also shows up in the infancy. And they are now waiting for this child to turn 6 years old for a transplantation. Minimum age of transplantation in certain centers is 6 to 9 years of age. So this maternal aunt has 2 sons who are unaffected phenotypically and have children who are unaffected phenotypically. The maternal aunt and her daughter, who eventually has this child, are unaffected phenotypically, but we don't know what their genotype is. But in the absence of a genotype, this is helpful in telling us that this is a familial pattern of disease and what pattern of disease it is. So the take-home message really is not to overrule the presence of ILD in young patients. You know, when you see a young patient who has symptoms of an ILD, that is actually a lot more worrisome and concerning than someone with a typical pattern of disease. Of course, in younger patients, consider atypical causes and always remember to partner early with a ILD center. And we're open for questions right now. This, I just thought, would be interesting. The thought of sand in the lungs is a very nauseating thought for pulmonologists, but this is a nice sand sculpture that I thought I'd share. And we're
Great,
open for
thank
questions.
you. Great, thank you. Thank you, Saniya, for the presentation. Okay, let's see the question. So we have one question about pulmonary fibrosis in sarcoidosis. Is that about the diagnosis and the treatment? Is that right? The pulmonary fibrosis, sarcoidosis, diagnosis and treatment? So I think the pulmonary fibrosis and sarcoidosis, you have to, first of all, lung involvement, you have to classify, is that which stage the patient has, is it stage 1, 2, 3, or 4, depending like if the patient have lymph node involvement only, or interstitial lung disease, or lymph node plus interstitial lung disease, or advanced pulmonary fibrosis. But in patients with advanced pulmonary fibrosis, once you establish the diagnosis of sarcoidosis, then you have to treat with immunosuppressant. Establish first, see the extent of the disease, severity of the disease, and treat with immunosuppressant. Usually, like in sarcoidosis, it depends also if your patient has purely lung involvement or if they have other what called extra pulmonary manifestation. Because I think in extra, if the patient has joint involvement, skin involvement, then the treatment of choice will be methotrexate. But if they have purely lung involvement, methotrexate will not work. You have to choose other medication. Most commonly, we are using azathioprine. What do you think, Sonia?
Yeah, no, you're absolutely right. You know, so what I would be very cautious about is not simplifying fibrosis to a one-size-fits-all. So sarcoidosis fibrosis is not the same as connective tissue fibrosis or UIP fibrosis. In sarcoidosis particularly, you always have to remain in search of active sarcoidal disease. So even sometimes in patients who only have fibrotic disease on radiographs, when you do nuclear medicine scans or PET scanning, you can actually pick up areas of activity which are consistent with active sarcoidal disease. And those patients will benefit from immunosuppressant disease, whether it's steroid or steroid sparing agent. So the sarcoidal fibrosis should not be lumped into fibrosis from the causes that we just talked about.
Yeah. If I might actually add something from an imaging perspective. So right now, the Society of Nuclear Medicine and the European Association of Nuclear Medicine, so the bodies responsible for nuclear medicine, have actually labeled PET-CT as the study of choice in the diagnosis and the staging of sarcoidosis. And it's a one-stop shop, where you can do the study that actually will show you bone lesions, liver lesions, splenic lesions, lymphadenopathy, that actually might guide you for biopsy, like inguinal or axillary, that you don't have to do a bronchoscopy and a biopsy. And actually, as you know, Saniya said, actually PET is also the study of choice for follow-up on treatment, because if the treatment is successful, all of those hot lymph nodes or lesions will become cold. And one more thing I want to tell the group as the clinicians is that this is 100% reimbursed by the MON. So if you order a PET CT and you say sarcoidosis, whether it was for staging or for follow-up, it will not be rejected. So that's 100%. We have actually talked to them. It's already in their books, and it is now the acceptable guidelines to use a PET CT.
Excellent, Dr. Mahmoud, thank you. So we have a second question. Is there any data about antifibrotic therapy in advanced familiar ILD, in particular IPF?
Yes, so you know the data is anecdotal in the sense that there are smaller studies in which patients have been started on these treatments. Now, considering that the genetic pattern, the genetics involved in familial disease is similar to idiopathic and sporadic cases of pulmonary fibrosis as well as the pathophysiology involved are similar. Therefore, the role of antifibrotics has been extended in the familial pulmonary fibrosis disease. Now, like we talked about, even within the same family with the same genetic makeup, the progression of disease can be very different. And so what we don't know, for example, in my patient, she has been the same for the last 10 years. So if I start her on antifibrotic, am I keeping her stable on the antifibrotic, or is that the way just that, or is that the extent of her disease going to be anyway, regardless? So, you know, these families, the number of families are so small which are being studied that at this time, we don't have clear data to suggest that antifibrotics may or may not help. Having said that, if you don't have any downside to it, particularly if you see that someone is rapidly progressing, then there is a role for the antifibrotics.
How about those patients who have familiar ILD? So if they have familiar ILD and they got the lung transplant, there's still a chance of recurrence. Is that right?
There absolutely is. And what's interesting is actually that now antifibrotics are actually the second debate that we're going to start hearing in the next decade or so is going to be initiation of antifibrotics in the post-transplanted population, whether they're familial or sporadic pulmonary fibrosis cases. And there is actually now evidence to suggest that the earlier initiation of antifibrotics in the post-transplant population is probably going to be the next thing that we're going to be looking at. Yeah.
Interesting. Great. Thank you. Let's see if there's any other question. If there's no question, great.
All right.
Perfect. I think is that the end of the cases?
I think so. Yes, our talks have finished. And if we don't have any more questions, I think the floor is open for discussion for open questions. Otherwise, we can bid each other farewell. All right.
Thank you.
Excellent.
Thank you very much.
You're welcome. Thank you.
All right. Take care. Have a good night, everyone.
Thank you. Thank you very much. Thank you.
Thank you, Doctor.
Thanks, Aled. Thank you. Thank you. Thank you. Bye.